Okay, let's unpack this. Think about having chickenpox as a kid. Seems like ancient history for most of us, right? Pretty standard.
Yeah, most people get it, recover, and that's kind of it.
But what if that virus, the one causing chickenpox, doesn't actually, leave your system?
Right. It just goes dormant.
Exactly. And then years, maybe decades later, it wakes up. And it causes something quite specific, not just a rash, but maybe paralysis on one side of your face. And it can affect your hearing, your balance.
That's Ramsay Hunt Syndrome. And that's what we're digging into today.
Yeah, this is our deep dive, and we're working directly from your revision notes on this.
That's the plan. Our goal here is to take all that detailed info you've gathered and boil it down. We want the really important high-yield points you need for revision or just to properly get your head around it.
Kind of cutting through the noise.
Yeah, exactly. Straight to the core stuff.
So we're sticking strictly to the material in these notes. We'll break down Ramsay Hunt piece by piece, what it actually is, the causes, who tends to get it.
The symptoms, how doctors figure it out, how it's treated, and what the outlook might be.
Yeah, the aim is to give you a clear, really structured understanding, all pulled from these sources you're using.
Okay, let's jump in. So, at its heart, what is Ramsay Hunt syndrome?
Well, the notes define it first as a viral infection. It usually shows up with this really painful rash, often around the ear, maybe the face.
Okay, painful rash.
But, and this is crucial, it's not just a rash. It very often comes with significant facial paralysis, weakness or drooping on one side, and other neurological things too.
And the virus causing all this?
It's the varicella-zoster virus, VZZ.
Ah, okay. The chickenpox virus.
The very same one.
Yeah.
It also causes shingles in adults later on. Ramsay Hunt is basically a specific type of shingles outbreak where the virus decides to target certain nerves in your head.
It's quite something that the same childhood virus can pop up years later and cause such different serious problems.
It really is. And your notes get specific about the neuroanatomy involved, which sort of explains why the symptoms are so varied. What do they highlight there?
Well, it shows how the virus reactivation can spread. The notes mention structures like the motor nucleus of cranial nerve. That's the facial nerve.
Controls facial muscles.
Right, that's where the paralysis comes from. Then there's the nucleus of the solitary tract, which can mess with your sense of taste.
Okay.
The superior salivatory nucleus that can lead to issues with producing tears or saliva.
Dry eye, dry mouth type stuff.
Potentially, yeah.
Okay.
And then involvement of the spinal nucleus of cranial nerve V, the trigeminal nerve, that relates to sensation, and it's linked to why you get those painful little blisters, the vesicles, in certain areas.
Wow. So it's not just hitting one spot. It can really branch out and affect multiple functions tied to different nerves.
Exactly. The virus is sort of traveling along these nerve pathways and causing trouble wherever it goes. That detail in your notes really spells out the pathology.
Which brings us to the why. We know it's VZV reactivating, but what actually makes it wake up after all that time? The etiology.
Yeah, the root cause is that reactivation. The VZV that's been lying dormant in your nerve ganglia since you first had chickenpox.
Just sitting there quietly.
Pretty much.
Waiting.
Are the triggers always obvious? Why now?
Not always, no. The notes say the exact mechanisms, the triggers for reactivation, aren't fully understood in every single case.
Okay.
But there's a definite strong link, mentioned in your notes, to a weakened immune system.
Okay, that makes sense. If your body's defenses are down.
The virus might see its chance. Exactly.
And that points towards the risk factors, right?
Yeah.
Who's more likely to get this?
Yeah. Your notes list the key ones pretty clearly.
So who needs to be particularly aware?
Okay, first off, you have to have had chickenpox at some point.
Yeah.
No chickenpox history, no dormant VZV to reactivate.
Makes sense.
Then older age, that's a big one. It's much more common in people over 60. Probably because, the immune system naturally becomes a bit less robust over time.
A compromised immune system is another major risk factor. So conditions like HIV/AIDS, maybe cancer treatments, or people taking immunosuppressant drugs for other reasons.
So anything lowering immunity.
Precisely. And interestingly, your notes also mention stress as a possible contributing factor.
Stress affecting immunity. Yeah, we hear about that a lot. So that could potentially give the virus an opening too.
It seems plausible. It fits that pattern of anything putting the immune system under pressure might increase the risk.
Okay, so the virus wakes up, immunity might be low, it travels along the nerves. How does that actually cause the damage, the pathophysiology?
Right. So once VZV reactivates, it starts moving along the sensory nerve fibers.
Okay.
And as it spreads, it causes inflammation. And that inflammation directly damages the nerve tissue itself.
And in Ramsay Hunt, the main nerve affected is?
The facial nerve, cranial nerve cyst. That's usually the one hit hardest.
Yeah.
And that inflammation and damage to the facial nerve, that's what directly causes the facial paralysis we see, and the other symptoms linked to that nerve's job.
So the pain, the loss of movement, it's basically the virus injuring the nerve through inflammation.
Exactly.
Yeah.
And that same inflammatory process, that's also what leads to the painful blistering rash, the herpes-zoster rash that typically pops up around the ear, maybe on the face, sometimes inside the mouth.
Okay, this is where it can get tricky for diagnosis because other things cause facial paralysis, which brings us to a really important section for revision. Differential diagnoses. What else could it be? How do you tell them apart?
Absolutely a vital point. You see someone with one-sided facial paralysis, Ramsay Hunt is definitely on the list. But so is Bell's palsy. Your notes really stress telling these two apart because they can look so similar at first glance.
What's the number one thing, according to your notes, that separates Ramsay Hunt from Bell's palsy?
The key difference is the pain, often severe pain, and that characteristic vesicular rash in Ramsay Hunt syndrome. Bell's palsy causes the sudden facial paralysis, yeah, but it typically doesn't have that intense pain or the blisters. So if you see paralysis plus the rash and significant pain, you really need to think Ramsay Hunt first.
That's the main flag. But you mentioned it's not always quite so clear-cut. Sometimes there's no rash.
Yes, the tricky one. Ramsay Hunt can happen without the rash.
Yeah.
It's called herpes-zoster synherpete. Synherpete meaning without herpes, without the rash.
Okay, so paralysis, maybe the pain, but no blisters.
Exactly. And in those cases, you really need lab tests, like doing a PCR test on saliva or ear fluid, maybe blood tests for the virus to confirm VZV is active and rule out other causes like Bell's.
Right. So classic picture has the rash, but keep the rashless version in mind, especially if the pain seems much worse than typical Bell's palsy. What else might look like this?
Your notes list quite a few possibilities. Lyme disease can cause facial palsy. Other viral infections could potentially do it too. If vertigo is a really strong symptom, you need to think about other things like viral labyrinthitis affecting the inner ear, or even, seriously, a stroke.
Right, need to rule those out.
And trigeminal neuralgia causes severe facial pain.
Yeah.
But your notes point out a key difference, that pain is usually paroxysmal.
Meaning?
It comes and goes in really intense, sudden bursts, often triggered by something like touch or chewing. The pain in Ramsay Hunt tends to be more constant, more deep and aching, though it can be very severe.
Okay, different pain pattern. And the notes had a longer list, too.
Yeah, quite comprehensive. Things like postherpetic neuralgia, which is actually a complication of shingles or Ramsay Hunt itself, lingering pain. Persistent idiopathic facial pain, which is just, well, facial pain without a clear cause.
Okay.
TMJ problems, temporomandibular disorders, ear infections, otitis, referred pain from somewhere else, and much more rarely something serious like a nasopharyngeal carcinoma pressing on nerves.
What?
So the main point here is that the clinical picture gives strong clues, but sometimes you definitely need those tests to be sure it's VZV or to rule out these other conditions.
That list really drives home why taking a careful history and doing a good exam is so important. So epidemiologically speaking, who gets this? You mentioned age earlier.
Yeah, just like shingles generally, your notes confirm that the incidence rate for herpes-zoster, which includes Ramsay Hunt, goes up significantly with age.
So older people are more at risk.
Definitely. It's most commonly seen in people over 60.
Okay.
And as we said with risk factors, people who are immunocompromised are also more likely to get it, and they might experience a more severe version too.
Right. Okay, let's really focus now on what someone with Ramsay Hunt actually looks like when they present the clinical features. What's the classic picture your notes paint?
The absolute hallmarks are usually severe pain, often felt deep in or around the ear. Then there's the unilateral facial nerve palsy, that's weakness or paralysis on one side of the face, cranial nerve 7. And then the characteristic vesicular rash, those little blisters, often in the ear canal, on the outer ear, maybe spreading to the mouth or the soft palate, following the nerve distribution.
So that trio pain, palsy, rash is the big clue.
Usually, yes.
But what other symptoms often come along with it, according to the notes?
Well, beyond that classic triad, it's very common to have vertigo or dizziness. Tinnitus is frequent too, that ringing or buzzing sound in the ear.
Okay.
And hearing loss. The notes specify it's usually sensorineural, meaning it's nerve-related hearing loss. It can be temporary, often is, but the notes warn it can sometimes be permanent.
Wow, permanent hearing loss is possible. Any other neurological signs mentioned?
Yes, because of the nerves involved, your notes mention altered taste sensation. And sometimes problems with eye movements can occur too.
And were there any other finer points about the presentation in the
A
notes?
couple of things stand out. The ear pain might start off very localized, maybe deep inside, before it spreads out and becomes more constant. And regarding hearing, besides loss, some people get hyperacusis, where sounds seem abnormally loud or painful on that affected side.
Increased sensitivity to sound.
Right. And really importantly for diagnosis and revision, the notes describe the pattern of facial weakness. It's a lower motor neuron, or LMN, pattern palsy.
Lower motor neuron. Remind us, what's the key practical point there for telling it apart from, say, a stroke?
Yeah, this is super high yield. An LMN facial palsy affects the entire side of the face, top to bottom, forehead, eye closure, mouth drooping.
Okay.
But the crucial thing, especially compared to an upper motor neuron lesion like most strokes, is that with an LMN palsy, the patient can usually still wrinkle their forehead on the affected side.
They can still raise their eyebrow.
Exactly. The forehead muscles get nerve supply from both sides of the brain, so they're often spared in UMN lesions. If someone has facial droop but can't wrinkle their forehead on that side, think LMN pattern like Ramsay Hunt or Bell's palsy. If they can wrinkle the forehead despite the lower face drooping, you worry more about a central cause like a stroke.
That forehead sparing is such a specific and useful clinical sign.
Really good point. And the notes also mention something about the timing of symptoms being a challenge.
Yes, they explicitly say the symptoms don't always pop up all at once. The severe ear pain might come first, maybe days before the rash or the paralysis appears.
Or the weakness first.
So the weakness first, yeah. This kind of staggered onset can make it really tricky to diagnose early on, before the full picture develops.
Yeah, you can see why that differential list was so long. You might see just one symptom initially and go down a different path until the other pieces fall into place. So once Ramsay Hunt is suspected based on these features, how is it actually confirmed? Especially in those cases without the rash. Investigations.
Your notes are clear. Diagnosis is primarily clinical. It really relies on recognizing those characteristic signs and symptoms during the examination.
But tests can back it up.
Oh yeah, absolutely. Especially
Right.
if the picture isn't classic. The main confirmatory test mentioned is PCR polymerase chain reaction.
You'd swab fluid from one of those blisters, if they're present, and test it for VZV DNA. Viral culture is another option, but PCR is generally faster and more sensitive these days.
And if there's no rash to swab,
Then you might use PCR on saliva, or tear fluid, or sometimes blood tests, looking for VZV antibody serology.
right, and beyond just confirming the virus.
Other investigations mentioned in your notes include audiometry, a hearing test that's really important to measure any hearing loss and track if it improves.
Okay.
Nerve conduction studies can sometimes be done. They give more detail about how badly the facial nerve is damaged and might help predict the chances of recovery.
And imaging.
An MRI scan, maybe specifically looking at the internal auditory canals where the nerves run, can be useful.
Yeah.
Particularly in atypical cases or if you need to rule out other structural problems.
So clinical picture first, but labs and other tests definitely have a role for confirmation, assessing the extent of damage or ruling out mimics.
That sums it up well. Oh, and one small but important detail from your notes. If someone keeps getting recurrent episodes of shingles, potentially including Ramsay Hunt, it's worth investigating for an underlying immune issue.
Good point. Recurrent shingles isn't typical. Okay, let's shift to treatment. Management. How do we treat Ramsay Hunt syndrome, especially thinking about the UK context from your notes?
The absolute #1 message from the notes on management is prompt treatment. Speed is really key.
Get started quickly. And what's the main treatment?
It's generally a combination therapy, antiviral medication plus corticosteroids.
Okay. Which ones typically?
Oral aciclovir is the usual antiviral mentioned,
Mhm.
and it's often given together with a corticosteroid like prednisolone.
And why that specific combination and starting it early? What do the notes say about the benefit?
The notes specifically recommend using both antivirals and corticosteroids promptly because the evidence shows this approach significantly improves the chances of recovery, especially recovery of the facial weakness, the paresis, and also any hearing loss.
So, starting early gives a better shot at getting function back.
That seems to be the strong message, yes. Timing is critical.
What about just managing the symptoms, supportive care?
Oh, absolutely vital. If the facial weakness means the eye can't close properly, eye care is paramount. You need to prevent the cornea from drying out or getting scratched.
Wow.
Your notes list, using protective measures like eye patches or taping the eye shut at night, plus using lubricating eye drops frequently. maybe thicker ointments.
Okay, protect the eye. What else?
Pain management is huge because the pain can be really severe. Your notes specifically mention carbamazepine as one option for that nerve-type facial pain, the neuralgia.
Right.
If there's vertigo, medications like antihistamines or anticholinergics can help suppress that dizziness. And then things like physiotherapy for the facial muscles, maybe counseling for the impact of it all, can be really important parts of the support system.
So it's really tackling the virus, the inflammation, and all the downstream effects. How does recovery generally compare to Bell's palsy?
Your notes make a direct comparison. They state that full recovery from the facial nerve palsy might be less likely with Ramsay Hunt syndrome compared to Bell's palsy.
So potentially more severe or longer-lasting damage.
It suggests that, yeah, reinforces that RHS can be a more serious insult to the nerve.
Which leads us neatly into the prognosis and potential complications.
Well,
What's the expected outcome and what might go wrong long-term?
yeah, the prognosis, the likely outcome, it does vary quite a bit. Depends on factors like how severe it was to begin with, and like we just stressed, how quickly that antiviral and steroid treatment was started.
What are the overall odds of getting facial function back completely?
The notes quote a figure around 75%. So about 3/4 of people achieve full facial recovery.
Okay, that's reasonably good, but it does mean about 1 in 4 might have some lingering weakness. Are there things that suggest someone might have a poorer outcome?
Yes, your notes list some specific poor prognostic factors. Being older is one. Having diabetes or hypertension are also mentioned as predicting a less favorable recovery. And interestingly, having vertigo as part of the initial symptoms is also noted as a poor prognostic sign for overall recovery.
Huh. Interesting that vertigo is linked to worse outcomes. What about the hearing loss?
That tends to do better, fortunately. Your notes say hearing loss usually recovers well. Only about 5% of people end up with persistent hearing problems.
That's more encouraging. Okay, now, the complications. What are the potential long-term issues we need to be aware of even after the infection clears?
Well, besides the risk of incomplete recovery of facial movement or hearing, the main complications listed in your notes include things like corneal abrasions, if the eye wasn't protected properly.
Right, damage to the eye surface.
The skin blisters can get a secondary bacterial infection, so that needs watching. And then a big one is postherpetic neuralgia, PHN.
That's the lingering pain.
Exactly. Chronic, sometimes really debilitating nerve pain that just continues in the area long after the rash itself is healed. It can be really tough to manage.
Yeah, chronic pain is a major issue. What else?
Other potential long-term problems mentioned are chronic tinnitus, persistent ringing in the ear, ongoing balance problems, chronic vestibular dysfunction. And sometimes scarring can occur if the skin lesions were particularly deep or got infected.
So it really underscores that even once the virus is under control, the damage it caused initially can have lasting consequences. Really emphasizes that need for early treatment again.
Absolutely. Minimizing that initial nerve inflammation and damage seems key to trying to prevent or lessen these long-term complications.
Wow. Okay, we've really walked through the whole story of Ramsay Hunt syndrome, following the structure of your revision notes, from the VZV virus waking up and affecting those nerves.
All the way through the classic signs like the rash and palsy, how it's different from Bell's, the tests you might do, the crucial early treatment.
And the potential outcomes and complications.
Yeah. So for revision, the real high-yield takeaways are, remember, it's a VZV reactivation. Look for that combo of painful rash plus facial paralysis. But don't forget, it can happen without the rash. For repeat.
Know the key differences from Bell's palsy. The pain, the rash, that LMN pattern with forehead sparing.
Exactly. And really internalize that prompt treatment with antivirals and steroids is vital. It offers the best chance for better recovery, especially of facial movement and hearing.
And maybe a final thought to chew on, building on what we discussed about diagnosis. Given that the pain, rash, and paralysis don't always show up together, and sometimes the rash is missing entirely, how does that challenge you clinically, maybe in a busy A&E or GP setting?
Yeah, it really makes you think, doesn't it? It highlights why you have to keep a broad differential diagnosis in mind for facial paralysis and maintain that index of suspicion for Ramsay Hunt, even if the picture isn't complete right at the start.
Yeah.
You have to be ready to connect the dots as things evolve.
Definitely requires careful observation over time sometimes. Well, this deep dive should give you a really solid foundation based on your notes.
Hopefully it makes those key points stick. Keep reviewing them, picture the anatomy, think through those differentials.
The more you work with it, the better it sinks in.
And listen, For more resources to help with your revision journey, don't forget to check out PassTheMSRA.com.
And also freemsra.com. Lots of great material on both sites to support your learning.